Bismillahirrahmanirrahim. Quote of the day: when the people of truth remain quiet against falsehood, the people of falsehood start believing it is the truth. Hazrat Ali. Critical appraisal of a journal article. I am Dr. Ahmad Wahid Khan, PGR, MPH, Community Medicine Department, King Edward Medical University. My supervisor is Professor Dr. Saira Afzal. Using the consort checklist for critical appraisal. Evaluation of an on-site sanitation intervention against childhood diarrhea and acute respiratory infection 1 to 3.5 years after implementation. Extended follow-up of a cluster randomized controlled trial in rural Bangladesh. Title: Identification as a randomized trial in the title. Yes, the author used the word randomized in the title to indicate that the participants were randomly assigned to their comparison groups. The title is clear and concise. Abstract: background diarrhea and acute respiratory infection are leading causes of death in children. The WASH Benefit Bangladesh trial implemented a multi component sanitation intervention that led to a 39% reduction in the prevalence of diarrhea among children and a 25% reduction of ARI measured 1 to 2 years after intervention implementation. Methods and finding. WASH Benefit Bangladesh was a cluster randomized controlled trial of water, sanitation, hygiene, and nutrition intervention. The sanitation intervention included provision or upgrades to improve latrines, scoop for feces removal, children potties, and in-person behavioral promotion. We enrolled a random subset of household from the sanitation and control arms into a longitudinal sub-study which measured child health with a quarterly visit between 1 to 3.5 years after intervention implementations. The study provided therefore included approximately 1 year of high intensity promotion, 1 year of low intensity motion, and 6 months of with no promotion. We assessed the intervention effect on diarrhea and ARI prevalence among the children less than 5 years through intention to treat analysis using generalized linear model with robust standard error. Masking was not possible during data collation, but data analysis was masked. There was no significant differences in the intervention effect between period with outcomes and limited data collected after promotion ceased. Conclusion: the observed effect of the WASH Benefit Bangladesh sanitation intervention on diarrhea in children appeared to be sustained for at least 3.5 years after implementation, including 1.5 years after heavy promotion ceased. Existing latrines access was high in the study setting, suggesting that improving on-site latrine quality can deliver health benefit when latrine use practice are in place. Abstract. Yes, the abstract does provide a structured summary of trial design, method, result, and conclusion. Now we talk about introduction. Diarrheal disease and lower respiratory tract infection are among the leading cause of death for children under 5 years worldwide. Access to improved sanitation reduce the risk of diarrheal disease in children under 5 years by about 25% on average. A recent meta-analysis shows that those average effects are primarily driven by studies on expanded sewerage access and intervention that improved water quality alongside sanitation, while solely latrine-based intervention trials have found no effect on diarrheal disease on average. Additionally, access to latrine does not equate to latrine use. Promotion of latrines use can achieve behavior changes in some contexts, although behavior intervention have reported mixed success in achieving latrine use among intervention recipients. Also, most studies have focused on documenting short-term uptake, while behavior changes has not been sustained in a small number of studies that access longer term latrine use. In Bangladesh, the sanitation intervention led to prevalence reduction of 39% for diarrheal disease, 25% for Giardia infection, 29% for trachea infection, and 25% for ARI. Notably, almost all latrine-based intervention trial conducted to date evaluated child health outcome approximately 1 to 2 years after the intervention was implemented. The long-term sustainability of water sanitation and hygiene intervention was recently recognized as a significant gap in the existing evidence. Few sanitation trials to date have demonstrated health impact and have only assessed effect over relatively short follow-up period. Little is known about how the effect of sanitation intervention on health might change over time. In this study, we assess the longer term effect of the WASH benefit Bangladesh sanitation intervention, which demonstrated reduced diarrheal disease and ARI among children to 1 to 2 years after the intervention implementation. We use longitudinal data from a random subset of trial participants collected between 1 to 3.5 years after the intervention implementation, including period with different intensity of behavioral promotion. Introduction: the scientific background has been explained very well. The study also explained its rational objectives are also explained. Methods: randomization and masking. The WASH benefit trials was a cluster randomized control trial that implemented water sanitation, hygiene, nutrition intervention in the rural Bangladesh and Kenya. The trial enrolled household of pregnant women in the first or second trimester in Bangladesh. Enrolled house were grouped into a cluster of 6 to 8 specially adjacent household. Cluster were spaced at least 15 minutes walking distance apart to reduce the potential spillover effect. Eight adjacent clusters formed a study block using a random number generator. Each cluster within a block was randomly assigned to one of six intervention arm: water sanitation and hand washing, nutrition, or water and nutrition. The interventions comprised visible material and in-person visits, so neither participant nor field staff were masked to intervention assignment. Data analysis was masked by replacing true intervention assignment with the re-randomized assignment variable. Intervention: the sanitation intervention included double pit pour flush, improved latrine, a sani scoop for the removal of child and animal feces, and a child's potty, along with in-person behavioral promotion on product use and maintenance. The interventions was delivered at the compound level, was emphasized on the index household where the pregnant enrolled live. New latrines were constructed to replace any latrine in the compound that did not have a slab or water seal or that failed to prevent surface runoff feces. A new latrine was provided for the index household if they do not did not own a latrine. 46% of index household did not own a latrine. Household without their own latrine in this setting typically share a latrine within the family compound. Sani scoop were provided to all household in the compound, and the potties were provided all household that had children less than 5 years. While promotion activities primarily target the index household, the other household in the compound were invited to participate and participated at well. Promoter did not visit household in the control arm. Behavioral promotion in the intervention arm was intensive. Six household visit per month on average by community health promoters for the first 2 years after intervention initiation until data collection for the parent trial was completed. Spot check observation and structure questionnaires demonstrated that the intervention increased access to and use of hygienic latrines throughout our study period, 1 to 3.5 years after implementation, while uptake was low and inconsistent for Seniscoop and potties. Sub-study design: a random subset of index household from the sanitation and the control arm of the parent trial were enrolled into the longitudinal sub-study that measured environmental contamination. In each block, we enrolled four households from the sanitation cluster and four households from one of two control cluster, which maintain the geographic matching from the parent trial. Trained field staff visited enrolled household approximately every 4 months for 2.5 years for a total of 8 visits between 1 to 3.5 years after the intervention implementation. The data collection period therefore included approximately 1 year of high intensity promotion, 1 year of low intensity promotion, and 6 months with no promotion. At each at each visit, field staff collected sample from the household environment and administered a structured survey on children's health, including diarrheal symptom, respiratory system, and bruising abrasion using the same survey instrument as the parent trial. Symptoms were reported for each child under 5 years present in the compound at the time of survey by the child's primary caregiver. We follow consort guideline in reporting the design and result of this trial. Ethics written in informed consent was provided. Study outcome we analyzed data according to a pre-registered analysis plan. Our primary outcomes were caregiver reported diarrheal disease and ARI in the past 7 days among the children under 5. Statistical analysis, we estimated that the prevalence of diarrheal disease and ARI during each month of the follow-up of separately for the sanitation and control group to observe temporal and seasonal changes. The prevalence of child health outcome was higher in this sub-study compared to the parent study, as the sub-study was conducted among the random subset of the parent trial participant, and the data collection period did not fully overlap between the studies. Sampling error, temporal variation in disease risk, and difference in children age could lead to differing disease prevalence between the study. To investigate the temporal variability, the impact of a child age, we compared the monthly prevalence of diarrheal disease during overlapping period when both studies were active, using the credible interval to account for sampling error. To measure the effect of the intervention, we pooled child observation across all 8 sampling rounds. We estimated the prevalence ratio and the prevalence difference, comparing the children living in sanitation and control household for each outcome using the intention to treat analysis through generalized linear model. Robust sandwich tender error was were estimated using study block. Effect modification, we assess potential effect modification by living in index versus non-index household in the compound. Periods of high intensity promotion versus low intensity or no promotion in monsoon versus dry season. We assessed effect modification by including an interaction term between each variable and study arm in regression model for each outcome. Methods, description of trial design, including all allocation, is given. The changes, important changes to method after the trial commencement uh, are also given, but reasons are not well explained. Participants, eligibility criteria was given. Setting, location where the data were collected were also mentioned. The intervention for each, both the groups are mentioned in the details. The outcomes, primary and secondary outcomes were also given. Any change to trial outcomes after the trial comments was also given with reason. Sample size, the sample size was not clearly defined. When applicable, explanation of any interim analysis and stopping guidelines was not applicable in this article. Randomization or sequence generation, they used a random number generator, and the randomization was also given. Allocation concealment mechanism was mentioned in the study. Implementation was not mentioned clearly. Blinding was not done here in this study. A statistical method was also given, which was the generalized linear model and robust sandwich standard errors. Method for additional analysis was also given, which was calculated by power calculation. Now results. We enrolled 720 index household and their familial compounds divided evenly between the sanitation and control arms. 80% of the household provided data for all 8 survey round and 96% completed at least 6 survey. Loss to follow up was similar between arms and participants that left versus complete completed the study were similar in their characteristic. At the first visit, approximately 1 year after the intervention was implemented, 10 compounds in the control arm, 3% had no latrines, while all compound in the sanitation arm had at least one latrine. During the same visit, 100% of index household in the sanitation reported primarily using a latrine in their compound for defecation compared to 97% of control and 86% of sanitation index household and 77% of control reported that adult always use the latrine for defecation. Latrines in the sanitation arm were less likely to be shared with other household than among the control 20% versus 54%, and there were an average of 4.2 compound resident per latrine in the sanitation arm compared to 7.1 in the control arm. 82% of index household in the sanitation arm reported that their primarily latrine was built or upgraded through the intervention compared to the primary latrine used by the index household in the control arm. Those in the sanitation arm were more likely to be poor flush, 99% versus 76%, and to have a functional water seal, 95% versus 46%. Over 95% of primary latrine both arm had slabs. The median any the median age of children at the first and the last visit were approximately 15 and 38 months respectively, and observation were divided evenly between male and female children. Child age and sex were well balanced between the intervention and control arm. The overall prevalence of bruising and abrasion was 8.2%. Of the prevalence was highest during the sixth round and the lowest during the first round. Fewer than 1% of observation were missing health outcome data and were not included in this analysis. Prevalence estimates for all outcomes were higher in this substudy compared to the parent trials, including during overlapping data collection period and after limiting parent trial data to sub-study participant. The prevalence of diarrheal disease among the children under 5 year was 19% lower in the sanitation arm compared to the control arm. ARI prevalence did not significantly differ between arms. The prevalence of bruising and abrasion was 13% lower in the sanitation arm compared to control, but the confidence intervals included the null. Effect modification intervention effect on diarrheal disease were modified between children living in the index household versus other household. The compound P is 0.15% and the season P is 0.02, but not by differing promotion intensity over the time. Among children living in the index household, the prevalence of diarrheal disease in the sanitation arm was 10.8% was 26% lower than in the control arm, 14.5%. The intervention had no effect on diarrheal disease among the children living in the household within the compound. During monsoon season, the prevalence of diarrheal disease in the sanitation arm was 27% lower than in the control arm. The intervention had no effect on diarrheal disease during dry season. There was no evidence of effect modification by any variable for ARI or bruising. Table shows the trial of this study. Result participant flow diagram was given and explained very well. For each group, the number of participants was randomly assigned and analyzed. For each group, losses and exclusion was also explained very well. The recruitment follow-up dates were defined in the study. Baseline data was not the demographic and clinical characteristic for each group was not given. For each group, the number of participants included in each analysis was given, outcome and estimation. For each, the primary and secondary outcomes were also given in this study. The binary outcome presentation of both absolute and relative effect sizes also mentioned, but the result of any other analysis performed was not mentioned. All imported harms or unintended effect in each group was not mentioned. Discussion. We found that the wash benefit Bangladesh sanitation intervention was associated with a reduction in the prevalence of diarrheal disease among the children under 5 years from 14.5% to 11.9%. Intervention effects were found exclusively among index household. The sanitation intervention reduced diarrhea by 26% among children living in the index household, while there was no effect for children living in other household in the compound. This finding further support the important role of intense promotion, providing both the study were similar. The 7-day prevalence of diarrheal disease among control was 16% in this sub-study versus 5.5% in the parent trial, and the prevalence of ARI among control was 26% in this sub-study versus 8.8% in the parent trial. One possible cause of these differences is sampling error among sub-study participants. Another potential cause for the discrepancy is measurement error. The parent trial used a lengthier questionnaire, and participants may have been less likely to report diarrheal cases due to survey fatigue. This sub-study was primarily designed as an environmental assessment of fecal contamination, and most of the household visits were devoted to environmental sample collection. In contrast, the data collection visit for the parent trial were more focused on the health questionnaire along with anthropometric measurement of children. It is possible that the participant in the parent trial reported fewer cases of child health outcome due to courtesy or social desirability due to the focus on the health. If correct, these explanation would suggest that the prevalence measured in this sub-study more closely approximates true population parameter. Previous study conducted in the same area estimated the prevalence of diarrheal diseases among the children between 10% to 18%, further supporting the validity of prevalence estimate of this substudy. While the 5.7% prevalence measured in the parent trial was lower than anticipated, the magnitude and direction of the bias in fact estimate from measurement error depend on the rate of over or under reporting of symptoms, and if misclassification was differential by study arm when symptoms are underreported and underreporting is non-differential by arm. Relative estimate of effect are unbiased while absolute effects are attenuated. Two additional pieces of evidence strongly suggest that the intervention did truly reduce the prevalence of diarrheal disease. First, the same intervention reduced the prevalence of Giardia infection by 25% and tricura infection by 29%, measured by the analysis of child stool sample demonstrating a true impact on enteric pathogen transmission using objectively measured outcome. Second, both the parent trial and this sub-study found uh, distinct seasonal effect of the intervention on diarrheal disease. Intensive early promotion in this efficacy trial may have enabled effect to persist beyond the duration of promotion. High existing access to and use of latrine indicate that sanitation norms may already have been in place and health. Further work is needed to understand how latrine adoption can be achieved and sustained in setting with low existing access to make larger strides along the sanitation ladder, and how sanitation programs can move toward broader approach of excreta management to effectively reduce fecal contamination in the environment and further improve health. Discussion. The trial limitation, the addressing source of potential bias was mentioned in this article. Generalizability of the finding also mentioned. The interpretation of a result with balancing benefit and harms were also given in this study. Other information, registration number and a name of the trial registry protocol was given. The full trial protocol and funding was not given. Source and sports was also not given. Summarization of the key point from this appraisal. Limitation changes have been made after the trial in selection of participant, but are not explained very well. Mentioning blinding was not done. Baseline demographic and clinical characteristic for each group were not given. Does not explain how the sample size was collected. Source of funding and support was not given. Implementation was not given. Does not mention its strengths. Strengths explain different screening measures, including primary and secondary outcomes. Measure gives important changes after trial commencement in the form of flow diagram, also mentioned. Explains the process of randomizing the participant into the trial, like sequence generation, allocation, concealment, and implementation. Give the limitation of studies, good statistical analysis along with different test to compare group for primary and secondary outcomes. Measure result for each group are shown in the form of table for each primary and secondary outcome along with effect size and its precision. 95% confidence interval. Thank you.